Hello, and welcome to today's lecture on musculoskeletal conditions with a focus on torticollis. My name is Kendra Gagnon. I am a pediatric physical therapist and a professor of physical therapy. So today we're going to describe how congenital muscular torticollis is defined, diagnosed, and classified, identify common impairments, activity limitations, and participation restrictions associated with congenital muscular torticollis, and describe the basic principles of physical therapy management of infants with muscular torticollis. And so obviously there are a number of musculoskeletal conditions that can occur in pediatrics. And so today we're just going to focus on congenital muscular torticollis as just one of those. So what is torticollis? Torticollis is a unilateral shortening of the sternocleidomastoid muscle. And so you can see here in this baby is experiencing torticollis, and this causes the head to tilt toward and rotate away from the affected sternocleidomastoid muscle. So if you think about the action of the sternocleidomastoid, that's exactly what it does. And so when that muscle is really tight, it's going to tilt, the baby's head is going to be tilted and rotated. Torticollis is named for the side of the involved sternocleidomastoid muscle. So in our baby here, in our picture, this is a right congenital muscular torticollis. And I've got kind of a picture pointed here to the muscle that's tight. And so you can really appreciate here that this baby's head is tilted to her right and then rotated to the left. Babies with congenital muscular torticollis may also exhibit an asymmetric neck extension and sort of a forward head posture. So you can't really appreciate that in this photo because of the angle. And you may also notice, particularly in babies who get a little bit older and have experienced torticollis and that has not been resolved, some craniofacial deformity. And we'll talk a little bit about that in a few minutes. So what causes congenital muscular torticollis? The etiology is unknown, but some theories include that there may be a direct injury to the muscle. So there may be ischemic injury, muscle rupture, infective myositis, neurogenic injury. So something kind of wrong with the muscle. This could actually occur during birth. So if we think about the birthing process as the baby comes through the birth canal, there's definitely lots of opportunities for their head and neck to be kind of positioned or moved in such a way that may cause injury to that muscle and then cause it to sort of tighten up. There also could be a hereditary component to this, and probably the most common one that we kind of think about and attribute torticollis to is an intrauterine compartment syndrome. And so basically what that means is if you think about when baby is towards the end of pregnancy and really packaged tightly in the womb, there's a lot of opportunity for that head and neck to get kind of positioned and twisted and for that tightening to develop. And this is kind of supported by the fact that we tend to see torticollis more often in firstborns. So that would be, during first pregnancy, it's tighter in the womb, and so because it's not kind of stretched out from previous pregnancies, so babies are packaged tighter in first pregnancies versus later pregnancies, and also because it's more common in multiple births, so twins, triplets tend to experience torticollis more often. So again, kind of seems like it may be related to being kind of more tightly packaged in the womb. So a kind of a really common associated condition with congenital muscular torticollis is plagiocephaly. And plagiocephaly just literally sort of means a misshapen head. And so the reason that plagiocephaly occurs with torticollis is because, the infant's skull is really soft and isn't completely formed and fused yet. And so when I tend to hold my head tilted and rotated, my skull is likely to become kind of flattened in one area because I've kind of continued to put pressure points on that area. So, and then that can actually go, and you can kind of appreciate in this baby here that we see kind of some flattening here, and then you really even see sort of it's subtle, but sort of an angling and asymmetry of the face. And so we really want to sort of watch that because that can become something that, again, if we don't intervene before the baby's skull becomes more fused and hardened, before their first birthday, this can become permanent and sort of so a permanently sort of misshapen head with those craniofacial asymmetries. Many babies develop plagiocephaly by sleeping regularly in one position or by spending extensive time sitting in the same position or in a car seat or swing. And so this is a really big issue and a huge thing for us to understand as we work with children and families who have plagiocephaly and torticollis. There does seem to be some torticollis and plagiocephaly that's acquired because babies are in baby containers all the time. So if you think about the car seats, the swings, the bouncy seats, even laying in their crib all the time on their back, babies don't yet have the ability to hold their head and neck in midline against gravity. And so they're kind of likely going to flop one way or another. And if they're continually positioned in the same way, in the same containers, or on their back all the time, that may actually start to develop flattening on the back of their head, which then leads the sternocleidomastoid to start to tighten up. So this is a big issue. We really have to make sure we're encouraging tummy time and helping parents understand that they've got to get those babies out of those containers, because we've seen a huge increase in torticollis and plagiocephaly since really kind of the explosion of baby containers. So these devices we put babies in, and also the back to sleep campaign where families are putting their babies on their back to sleep to prevent SIDS, which is critically important. But babies should always be on their backs to sleep, but we really want to make sure that we're encouraging tummy time to play. So differential diagnosis can be really important in congenital muscular torticollis. And so just kind of a few words on that. We need to make sure that the baby has received a thorough medical exam before we're initiating torticollis treatment and physical therapy. Sometimes muscular torticollis will present with what we call a quote-unquote tumor, which is just a palpable mass. So, kind of a knot in the muscle or a tight band in the muscle. And so that oftentimes will happen kind of within the first few weeks after birth, and then we'll notice that kind of head tilt and rotation. Of extensive history and physical exam can determine if the lesion is congenital or acquired, traumatic or non-traumatic. And, there should definitely be medical exams like x-rays to make sure that there's no congenital sort of spinal anomalies. We need to check vision, look at neuro, because again, asymmetries such as what we see in torticollis can also be a red flag for neurologic conditions. And so we want to make sure that medically that the baby has gone through kind of all of these different exams and assessments before we initiate that treatment for torticollis, to make sure we're ruling out something that's not really a purely muscular condition. There are a few different types of congenital muscular torticollis. Again, I mentioned the sternomastoid tumor. And again, that can be kind of a scary word for families. So we want to make sure they understand we're not talking about a cancerous tumor. It's just basically a palpable mass, not lump in the muscle. But x-rays are going to be normal. And you'll notice in all of the types of congenital muscular torticollis, x-rays are normal. We've ruled out any sort of kind of spinal deformity. This is a muscular concern. Muscular torticollis is when the muscle is actually tight. There's no palpable mass. So the baby holds their head in that tilted and rotated position, and it's tight and difficult to get them to move out of that position. And then postural torticollis is when baby is going to tend to hold their head in that tilted and rotated position, but there's not tightness. We can pretty easily move them out of that position. And so that's, obviously going to be optimal. So you can kind of start to move them out of that position and just kind of strengthen out of that position as well. So some impairments that we may see with congenital muscular torticollis, first and foremost is the range of motion limitation. And that's really right out the gate what we see. Babies unable then to achieve midline alignment because they're holding that head kind of tilted and rotated. So now they're unable to get their head and face to midline, which then can sort of start to interfere with their ability to bring their hands to midline and hands to mouth. And, so this can kind of become an issue for future development. We may see muscle imbalances, craniofacial asymmetries can develop, as we discussed earlier. compensatory movements, a persistent asymmetrical tonic neck reflex. So again, because baby's kind of always over to that side, we might kind of see that persistent ATNR, particularly to one side. This can also impact their ability to feed and oral motor skills. So again, kind of being able to get my head and face in midline and really have that sort of control and ability to stabilize my head and neck so that I can use my mouth muscles is going to be impacted. In addition, having difficulty rotating their head to one side may impact the ability to nurse or feed on one side or another. So those can become a feeding issue as well. When we do put baby in their tummy, they may have particular difficulty lifting their head and may be particularly fussy with tummy time. Once they start to sit, you might see them kind of elevate their shoulders and kind of stack their head on their shoulders because again, they didn't get to develop those nice neck and upper body muscles. So you might see kind of these no neck babies that stack their head up on their shoulders to sort of compensate for that weakness. And again, looking way forward, if this doesn't get, the intervention doesn't occur, the asymmetries can actually lead to scoliosis. So looking at activity limitations, what we often can see is ipsilateral hand and visual neglect. So again, if I'm always oriented to that side, that can impact my ability to kind of pay attention to the other side. Inability to kind of prop up nicely and prone, difficulty learning to roll. Limited sensory development, really, because I'm not able to kind of explore my environment. Maybe this is limiting my ability to bring my hands to my mouth and put toys in my mouth and really explore my environment. Again, if we're not able to kind of get this treated and nipped really early on, baby may experience asymmetric sitting, walking, crawling, and transitional movements. Fine motor control can be an issue. So if I have difficulty bringing my hands to midline or crossing midline, that's going to impact my ability to develop good fine motor skills. Poor postural control and just general atypical acquisition of motor milestones can occur. So the good news is that even though we know that there are all these sort of impairments and activity limitations that can occur, particularly for babies who don't get their torticollis sort of resolved within the first few months of life, what we do know is that torticollis is generally really easy to treat. Over 90% of babies respond to conservative intervention and don't go on to have these long-term effects, don't go on to require, surgery or bracing. So we can really have a huge impact on these babies early on. And really, treatment is pretty simple. If the right sternocleidomastoid muscle is tight and I'm tilted to my right and I'm rotating to my left, then really what we need to do is range of motion and stretching that tilts baby to their left and rotates to their right. Similarly, we're going to try to strengthen those opposite muscles. So we're going to position the baby and do activities to really encourage them. Again, if it's that right muscle that's tight so they're rotated left, we're going to encourage them to rotate to the right. We're going to encourage them to right their head up to the left side. We're going to work on postural alignment. We're going to work on positioning. So we're going to try to get the baby in position, and we maybe even will use, positioning rolls, maybe towel rolls to get them in in midline, get their hands together. We may do some massage to the muscle. We're going to work on those righting reactions because, again, if baby's tilted to the right, one of the best ways that we can work on them kind of moving their head in that opposite direction is kind of working on that, righting reactions where we're maybe tilting them on our lap or the couch cushions or a ball so that they're trying to lift their head to the left to come back upright. Developmental exercises are always going to be part of the plan. We're going to be working on midline. We may be doing some feeding, rolling, tummy time. And parent education is huge here. We need to teach the parents to stretch because we're going to need parents doing those stretches every day, multiple times a day. We're going to talk to them about positioning, back to sleep, tummy to play, get those babies out of containers, hold them, switch the sides you're holding them, switch the different heads of the bed that they're positioned on. So we're going to teach them lots of strategies to kind of encourage that, that active movement towards the opposite side. And again, the stretching protocol is pretty simple, and you can really pretty easily online find, different stretching protocols for torticollis, but they all are pretty much the same. So this is just, I've kind of written one out here. Babies usually supine on a bed with their head and neck free of the surface, so you're kind of holding and supporting them. You want to stabilize the shoulders, and luckily babies are tiny enough that you can do this. So you're going to be kind of holding their head in one hand, and then maybe have your hand placed across them to stabilize their shoulders. You may give just a little bit of gentle traction, and then you're just going to do those stretching movements. So whichever one you're working on, whether you're rotating, you're laterally flexing, you're doing some asymmetric flexion and extension, midline rotation. Again, depending on the particular baby, their type of torticollis and how they present, you're basically just going to be stretching them out of that tightness. So as I already mentioned, the vast majority of cases of torticollis do resolve with conservative treatment. But for the very small percentage of infants who do not experience a successful resolution of torticollis, surgery can be indicated. But usually we try at least 6 months of conservative treatment. And again, it's very, very rare for a baby to require surgery, particularly if the torticollis was truly muscular, and particularly if the torticollis was caught and treatment was initiated within the first few months of life. Botox injections can be used for torticollis. Botox injections it's botulinum toxin. It literally just inhibits the release of the neurotransmitters that cause muscles to fire. So it really prevents those muscles from firing. Once Botox is injected, it's usually effective for a couple of months before the effects kind of wear off. And so some children do get Botox injections to sort of keep that sternocleidomastoid muscle from firing, to literally just stop that release of the neurotransmitter, and then try some of that aggressive sort of stretching and strengthening while the Botox is in effect, to see if you can get an effect there. Orthotics can be used. There are some orthotics that may be used for children who have this. And plagiocephaly, for kids who have plagiocephaly, we often use the dynamic orthotic cranioplasty band, or a dock band, which basically looks like a little helmet. So you've probably seen babies, out in the community, out shopping in the mall, at the park, that are wearing a little helmet. And if you see that, chances are they have plagiocephaly, and they are wearing that helmet to try to kind of reshape their head. So that is all I have for you today on torticollis. Thank you for listening, and we will see you next.